Hi and welcome to our SatScreen reporting deep dive video series. In this video, we will be reviewing the cycling time and cycling severity graphs that appear on the first page of the SatScreen report. Before we get started, all examples herein are intended to demonstrate cases where the reference condition may be likely. SatScreen reports are intended for use as an objective screening tool only and should not be used to diagnose any disease or condition. The definition of cycling is an occurrence of one event triggering another. In the raw data graphs, SpO2 and pulse cycling segments are denoted by black horizontal lines. SpO2 and pulse cycling often co-occur, however, it is possible to have cycling in only one channel. SpO2 cycling time is an indicator of ventilatory instability, a recurrent pattern where one respiratory event triggers another. Cycling severity is an indication of how severe the patient's apnea events and starting SpO2 levels are. Combined, they can tell you more about the type of sleep apnea the patient is having. Now that we have an understanding of cycling time and cycling severity, we will go into three pattern studies: high cycling time and high cycling severity, high cycling time and low cycling severity, and lastly, low cycling time and low cycling severity. Our first pattern has high cycling time and high cycling severity. This may indicate high risk of sleep apnea. This pattern is indicative of severe ventilatory instability, sometimes caused by high loop gain. Typically coincides with risk of severe or complex sleep-disordered breathing. A study examining OSA pathophysiology and the response to oral appliance therapy found that greater response to therapy occurred in patients with a mild anatomic compromise and a lower loop gain. Therefore, patients may respond better to alternate therapies, such as PAP or a combination PAP-OA therapies as a first line of treatment. Additionally, introduction of sedatives or narcotics may increase risk to the patient. Apnea or hypopnea lead to severe desaturation before the patient has a life-saving arousal and recovers. The arousal threshold is dampened and the pattern is repeated frequently throughout the study. Our second example shows the same high risk of severe ventilatory instability. Here, an abnormal RDI is combined with a high cycling time of 66% and a high cycling severity of 191. In the fully graphed out night, we can see the respiratory event that leads to the severe desaturation causing the cycling pattern. Our final example of high cycling time and high cycling severity again shows an abnormal RDI combined with a high cycling time of 94% and a high cycling severity of 411. This means that 94% of the valid recording was spent in a pattern of recurring desaturation events. Based on the high cycling severity, it indicates that the desaturations were substantial and occurred with very little recovery time in between events. Our second pattern has high cycling time and low cycling severity. This may indicate risk of sleep apnea with a low respiratory arousal threshold. In patients with low arousal threshold, indicated by higher cycling times with lower cycling severity, increases in ventilatory drive can cause arousal from sleep, which then destabilize breathing and sleep. Research examining CPAP adherence found non-obese patients with low arousal threshold are markedly poorer at adhering to CPAP long-term. In this case, an arousal due to minimal upper airway obstruction leads to startled breaths, resulting in compensatory drop in ventilation and airway tone, creating a brief obstruction causing arousal, leading to recurrent events. Our second example shows the same risk of OSA with low arousal threshold. Here, an RDI of 13 is combined with a high cycling time of 26% and a low cycling severity of 31. In the fully graphed out night, we can see an arousal caused by an upper airway obstruction that leads to the desaturation causing the cycling pattern. Our final example with a high cycling time at 20% and a low cycling severity at 23 is paired with an RDI of 6. As stated in a previous case, a study examining OSA pathophysiology and the response to PAP treatment found that patients with mild anatomic compromise and a lower loop gain respond poorly to PAP treatment. Our final pattern has both low cycling time and low cycling severity. This does not mean that they do not have sleep-disordered breathing, only that their ventilatory and arousal responses to a desaturation event are relatively normal, as we can see here. This case is one where there is still a risk of OSA without the presence of cycling. Our last example with a low cycling time at 8% and a low cycling severity at 5 is paired with an RDI of 7. In the raw data, we do not see large periods of cycling, but with an RDI above 5, there is still the risk of OSA. That's the end of this video. Thank you for watching.